Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist here at Peter Mac in Melbourne, joined as ever by my host, Renu Epen. How are you, Renu?
Good morning, Declan. It's been interesting times for us in Melbourne. Yeah. We're in the aftermath of protests and earthquakes and late-breaking abstracts at ESMO.
Yeah, it's been quite a week, hasn't it?
It's been quite a week,
Bloody earthquake yesterday. That was very entertaining.
I think
first thing in the morning.
It would have brought back a lot of memories of Christchurch for many urologists.
Yeah, it certainly did for me.
Yeah,
we were stuck in Christchurch 10 years ago when the big one went off. The USAN's meeting was happening and I had a total flashback yesterday when the building started shaking.
Me too.
Oh my God, that feels like that bloody earthquake.
Yeah.
But there you go. Anyway, we won't need to talk about the earthquake today, but we have some sort of earth-shattering paper to discuss. Did you like that segue?
Along the same theme.
Very cheesy. So today we want to talk about ESMO because, of course, ESMO happened at the weekend in Paris and there were a couple of massive prostate cancer papers that came out of it this week, plus a bunch of other stuff. And we could talk about the whole bunch of stuff, but what we've decided to focus on today is one of the really big ones from the presidential session, and it was the latest data from STAMPEDE on the M0 high-risk patients.
Yeah.
And so we're joined in the studio as well today by our colleague here at Peter Mac, Associate Professor Arun Azad. Good morning, Arun. Thanks for coming in.
Morning,
Thanks, Declan and Renu. It's very, very early for a medical oncologist, so if I fall asleep, just poke me and I'll wake up.
Well, I'm very impressed because here in Melbourne, we had to get Arun here at 5:45 in the morning, and this is before start time, isn't it? Yeah.
I think medical oncologists are banned from the hospital that early, aren't they? So you're not allowed in the. I somehow snuck in anyway.
Yeah, well, get used to it. He looks good, doesn't he?
He does. He looks ready.
I think it suits him. Yeah.
I left my wife with our baby, and normally I get up early and take care of him to give her a bit of a sleep in, but anyway, I'll pay the price later.
He's a new parent. He's used to surgical hours.
Yeah, he is. Well, great to have you, Arun, and thanks for coming in. And I think the big part of the reason why he agreed to come in at this ungodly hour of the morning is that we have a couple of fantastic guests on this morning, dialing in from Europe, who are investigators, authors on this big STAMPEDE paper that we've got. And so it's a great privilege to welcome them, old friends of us here in Australia, and me as a proud European. It's a great pleasure to welcome Professor Noel Clarke, urologist from the Christie in Manchester and Professor of Urological Oncology. Noel, good evening in the UK and thank you very much for joining us.
Hello everyone, it's a pleasure to be here.
Well, thanks so much. And Noel's actually on holidays down in the West Country in England, but has kindly agreed to dial in for a bit of distraction this evening. So thanks very much, Noel. And also joining us from Switzerland, Professor Silke Gillessen, very well known to lots of Australian crowds here. Silke, medical oncologist at the Oncology Institute of Southern Switzerland. Silke, thanks so much for joining us this evening.
Thank you for inviting us.
Yeah, so look, thanks very much. And we'll go straight to the business because both Noel and Silke are very involved in STAMPEDE. Of course, Noel was one of the original co-PIs that set STAMPEDE up, that planned the whole thing, this amazing multi-arm, multi-stage study. What were your thoughts on STAMPEDE just as an entity, Arun, before we get into it?
Yeah, I mean, I think it's certainly within prostate cancer, and I think almost across medical oncology in general, it's a unique entity. I mean, to have produced, so many, landmark practice-shaping, practice-changing papers from the one adaptive clinical trial platform is, remarkable. And to continue to do it, I think I'm not sure that anywhere else in the world could replicate it outside of the UK. It's obviously extended to Switzerland as well, but it's an incredible entity. We certainly could never do that in a country like Australia. So hats off to Noel and Nick James and all the other amazing team at STAMPEDE.
Yeah. Congrats, Noel. Take a bow again on behalf of STAMPEDE. We salute you.
Thank you. Well, if I could say, I'd like to take a bow on behalf of all the people who've participated in STAMPEDE. We have over 140 centres in the UK and Switzerland. We have about 11,000 patients in these first phases of STAMPEDE, and we've just planned the next 10 to 12 years of the trial. So it's going to run and run. So it's been a big international effort. And thanks to all who've taken part in it.
Yeah, for sure. And I know both yourself and Silke are on the strategy committee, but for those who aren't that familiar with it, the uniqueness of this continuously running platform where there's a continuous control arm of patients starting ADT for their nasty prostate cancer, and then you keep adding new intervention arms. So I remember Nick James, your co-PI colleague, shows this amazing graph of how long it took to get the first arm running, which is very typical for starting a randomized trial and adding all the sites, and then how quickly you add all the rest of the arms because it's already up and running. You're just adding an arm. And so it's an incredibly efficient way of testing something new against the standard of care, and also being able to adjust the standard of care based on your own data. So the control arm today is very different to what it was 10 or 12 years ago, I recall, when I was working in the UK when STAMPEDE started.
Yes, and I mean, it's been very gratifying to see. I mean, the recent recovery trial, which is the big COVID-19 trial, run in the UK, which proved that dexamethasone was effective in COVID-19, was based on STAMPEDE. And it's now started to become a model, the MAMS model, the multi-arm, multi-stage model, for other trials such as malaria treatments, various infectious diseases of different types, and of course many other cancer trials. So I think it's been quite groundbreaking of itself as a trial design. Yeah. And that was down to the team at the MRC, Max Palmer and co, who came up with the concept.
Yeah, fantastic. Well, great acknowledgement. And we'll put links out to the STAMPEDE website in the show notes. So let's go and talk about this presidential address that your colleague Gert Attard presented at ESMO at the weekend, Noel. So this is, it's not a unique arm actually of STAMPEDE, is it? It's a combination analysis that was done, but in a really interesting population. It's in the so-called M0 high-risk population. So can you just give us a quick overview of this population and then of this study?
Well, yes, thanks, Declan. When we first conceived the study in 2004, I think we just had a different idea of the natural history of M1 and M0 disease. We didn't really understand it that well. And what turned out was that M0 disease had a much longer natural history than the patients who presented with de novo metastatic disease. It seems obvious now, but it wasn't as obvious then. And so we planned it for what we termed high-risk prostate cancer. In other words, prostate cancer that we thought people were going to die of if they weren't treated effectively. Now, as the trial evolved, it became clear that the M1 and M0 needed to be split off for analysis. So we've always reported M0s and M1s together, but we've sub-reported the M1s, where most of the big hitter papers have been. And of course, we've had to wait for the M0 population to mature, because STAMPEDE is not analysed on the basis of time. It's analysed on the basis of events in the control arm of the study. So naturally, the M0 control arm events were quite extended. So that's the rationale behind us splitting it off. Now, for M0 high risk, we had a category which was two of three criteria. One was a T3, T4, PSAs of 40 or more, or any Gleason 8 and above. And if you had two of those three criteria, you got into the trial as an M0 patient. So in fact, that actually fits quite a number of patients that are currently, we would regard as high risk, who are currently having operations or radiotherapy. And we further added a modification to the trial after the publication of the SBCG7 and PRO7 NCICP3 trials, which showed that radiotherapy plus ADT was a standard of care. So for the purposes of this element of our report, that's the ABI and ABI-ENZA combinations against standard ADT, radiotherapy was mandated for all these patients. Now, we had about 2,000, just under 2,000 patients in this group. And when the ICECAP collaboration reported its findings in 2017, and a number of us were involved in that, this was coordinated by Chris Sweeney and the team in Boston. It pulled in all the trial data from MRC trials, EURTC trials, and so on, and the American trials. So that showed from 24,000 patients included in that analysis that metastasis-free survival was a direct surrogate of absolute survival in M0 disease. So when that result came out, which is 2017, we as a trial management group got together to reconsider our endpoint, because our endpoint originally was overall survival. And of course, that's a long endpoint in an end-0 trial. So we decided two things. One was to elect to have metastasis-free survival as the endpoint. And the second thing was to put together the ABI-ADT and the ABI-ENZA ADT arms of the trial. Now, they started at different time points. ABI started in and around 2011, 2012, and ABI-ENZA started in and around 2014. But the control arm was the same, and all the measures were the same. So we had something like 5 years follow-up for ABI-ENZA, and we had, I think, a median of something like 72 months overall for the trial. So it was long enough to get a decent measure of the endpoint and to have enough events in the control arm. So that really was the basis for our analysing the study and presenting it at ESMO this time. And we've now got a paper in submission currently to one of the major journals. So the details are all there. Now, what we found was it made us all smile. You need a bit of luck when you're running a trial. So many people work in trials, so much effort goes in, and the trial is often negative. And when it comes out positive, well, everybody has a big smile on their face, and you think, right, this is going to make a difference. And I think it will. So we had a median age of 68 years, and the median PSA was 34. And virtually all of the patients had radiotherapy, so the primary. Now, the important thing in the protocol was that the combination therapy, that's ADT-ABI or ADT-ABI-ENZA, was only given for 24 months. It wasn't given continuously. And that was a conscious decision because we felt that M0 patients had a much better prognosis. And most of the patients got a full 24 months. The combinations got a little less. That was about 21 months, just under. And they had to stop largely because of added complications. I'll come to that in a minute. Now, when we looked at the major endpoint, which is metastasis-free survival, what we saw was a major difference, a hazard ratio of 0.53, which is a really big difference in a trial with a 6-year metastasis-free survival improvement from 69% to 42% to 42% to 82%. And that's a big difference. And we know that MFS is a direct correlate of OS. And when we plotted the metastasis-free survival for both ABI and ABI-ENZA combinations, we didn't see a big difference. The hazard ratio was the same, and although one trial had run for a little longer than the other, one element of it, should I say, the survival curves were almost identical. So what we concluded from that was that the combination was effective, but the enzalutamide didn't seem to add anything to the abiratrone other than complications, which I'll come to in a minute, as I say. We found that this was effective across the piece, whether the patients had no positive or no negative disease on conventional imaging. That's important to stress. It didn't make any difference whether you were under 70 or over 70. There were some differences with the poorer performance status patients, but pretty much the drug combination worked across the whole spectrum. When we come to overall survival, we were quite pleased to see that we didn't see an excess number of deaths as a consequence of the treatment, but we did see a general improvement in survival with the combination. That hazard ratio was 0.6. But looking at that in more detail, when we came to prostate cancer specific survival, in other words, this is prostate cancer which is causing death, we found that there was a halving of the prostate cancer death rate for the duration of the trial. And when we looked at progression-free survival, well, there was a huge reduction in the number of patients progressing. That hazard ratio was 0.44, with a huge p-value. I think it was 10 to the minus 15. We did see adverse events, predominantly in the combination arm, and those were manifest largely as fatigue and hypertension. So our overall conclusion from the study, which was very strongly positive for the use of the combination, was that 2 years of abiratrone-based therapy significantly improves metastasis-free survival, overall survival, and prostate cancer-specific survival in this group of high-risk N0 patients starting ADT, and that it should be considered as a new standard of care. And our secondary conclusion was that the addition of enzalutamide to abiratrone really didn't do anything for efficacy. It simply added to the complication rate. So we'll now be going forward with pursuing this, certainly in our country. We have to seek funding and recognition for this, but the detail will be out, I hope, in one of the major papers. As I say, we have the publication in already to one of the major cancer journals, and that will be at the mercy of the reviewers, but I'm confident that it will get in somewhere at a very high level. So that's where we are, and I hope we've changed the standard of care.
I think you have.
We should just end the podcast
that's
right now.
just
That was
amazing.
such a fantastic summary.
Brilliant summary, and it summarised why there is so much interest in this paper. Really big thing, and that's true, Silke. We'll go through some of the detail and ask the questions in a second, but it's a very accurate take-home message, isn't it? That this is practice-changing. I remember it was like after Charted, you're feeling it immediately. I felt it yesterday when I was seeing patients, an international patient I was advising, that I said, well, I think this is the new standard of care in your situation. Is this true, Silke?
Yeah, clearly also for us. So I think, I don't know what Noel thinks, but I really was the overall survival benefit of with a hazard ratio of 0.6 was really also for us probably a surprise, right? It was so good. And I don't know, Noel, if you mentioned it. So there were also, I think, patients, we should maybe mention that high risk defined by node positive disease. So I guess that was an important part as well of the patients. And there, interestingly, NCCN had already had abiratrone since, I think, last year in their algorithm for treatment, because Nick James showed once, remember, that kind of very preliminary data of the ABI only arm that we reported together with the M1s. So I guess a little bit we had already the feeling, but now obviously we have much better data.
Yeah. No, Arun, what do you think? Is it going to have immediate acceptance here as a change in standard of care, pending regulatory approvals and so on?
Yeah, I think it does, Declan. I mean, the challenge here, and we'll probably talk about it more, is incorporating into the imaging paradigms in Australia, where these men get PSMA PETs, and then many of them will have more advanced, there's stage migration, and then how do people interpret that? But my argument against that is that in the end, the imaging is just what you detect on your imaging tool is just a function of its sensitivity. And so these men with M0 by conventional imaging, we know many of them will be upstaged by PET, but it's the same biology, it's the same cancer. It's just you're detecting more cancer with a more sensitive imaging with more sensitive imaging modality. And in the end, what it shows is that two things for me is that the androgen receptor, is the key, is the king for everything we talk about in all other therapeutic modalities. The androgen receptor is still, has always been, is still, and will always be the king in terms of prostate cancer therapy, systemic therapy, and then earlier use of these drugs. We've seen it from M1 CRPC, post chemo, then pre chemo, then non-metastatic CRPC, and MHSPC, and now M0, castration-sensitive disease. We just see a consistent and increasing benefit from these drugs, from using them earlier. And if you're a patient, in this situation, you'd want these drugs earlier. For all the discussion around imaging and access and cost and toxicity, if you're a patient who fit the criteria for this, was your relative, you're the patient, you'd want 2 years of ABI. I mean, it's clear. It's very clear for all the other noise that happens. It's clear that patients would want this.
And we will go on and talk about imaging in a moment, I suppose. But I do agree with your point. I think that it's not that important, interestingly, because what has typically happened here in Australia, as Noel and Silke know, is that this type of patient who turns up 68 with a PSA of 34 and has a biopsy will get a PSMA PET CT as their initial staging, and that's because it's post-pro PSMA and it's easy to access. And yeah, sure, a lot of these will actually have some degree of metastatic disease that you'll see on a PSMA PET. And interestingly, then our usual challenge is trying to say, well, this is M1 HSPC visible on novel imaging only. How are we going to extrapolate from ENZA-MET and Titan and STAMPEDE and CHARTED into this population? Because we're always thinking, well, we're going to do some sort of combination therapy. Is it high volume, low volume, etc.? But so it only complicates it for us. Whereas actually, if you look at the current STAMPEDE data and say, well, is he M0 on conventional imaging? Then we now have a brand new, easy to understand paradigm that we can offer these patients without even worrying about what the PET scan shows.
And I don't think we should underestimate the potential importance of local control. You know, Declan, again, I think sometimes when you upstage with PET, sitting in MDT meetings, tumour board meetings, whatever you want to call them, as a medical oncologist, it's interesting sometimes seeing nihilism from certain colleagues about local therapy. And I think, STAMPEDE, reinforces the importance of that in terms of oncological control for local disease, but also, would STAMPEDE have achieved the same if they'd just given Abi plus or minus, or versus Abi plus or minus ENZA without the local control, without giving radiotherapy? I don't know that it would have. I mean, we know there's a synergy between radiotherapy and androgen, targeting the androgen receptor. So I think it's a good reminder that we should not exclude or forget about local control, even in these patients with very high risk disease.
Noel,
can I ask something? Because you said metastatic on PSMA PET only. So, but how do you know that? Are you always doing also a bone scan? And obviously probably the CT scan you have with contrast in your, I don't know how you're doing it. Are you always giving iodine contrast as well for the CT scan of the PET?
So the answer is very often we're trying to extrapolate backwards and we're looking at them in the tumour board, and we can see the CT component because initial staging CTs get a contrast CT, so at least you've got that, and we can see sclerotic lesions, but we only go back and do a bone scan for these patients if it's to fit a trial or really to help with management advice on it, I think. So it is an extrapolation, and for example, a typical tale from that here is we now have these M0 CRPC drugs approved in Australia. But as you know, we've shown that almost all those patients are M1 on novel imaging. But to meet the regulatory or the other approval, we'll go backwards and do conventional imaging just to prove that they are M0 CRPC. We don't want to end up doing that. But look, as you know, the reality here is that these patients in Australia will have initial staging with PSMA PET. And it's kind of is just the way it is. But I think for the audience out there listening who might have access to PSMA PET in other countries as well, it is important to remember the simplicity of what STAMPEDE showed is that these patients benefit, as Arun re-emphasized, from combined approach targeting androgen synthesis pathways. And we shouldn't try and overcomplicate it too much with PET imaging. But I'm very interested in your thoughts on that, Silke. How is PET imaging going to fit into this?
Yeah, I guess we need to have a lot of new data for that. So I have to say, in that situation right now, it makes also a lot of problems, right? Especially because I know you're using gallium PET CT, but is probably a bit more specific. Whereas in a lot of other countries, for example, here in Switzerland, we're using now fluoride. And that goes much more on specifically to the bone. And I've seen too many patients with some PSMA spots in that fluoride PSMA PET that have never been really confirmed to be metastasis. And that's Owen also said, right? And then they all of a sudden go into a palliative treatment setting. And that I find a bit dangerous. And also we have always the same thing, right, Noel? I mean, I remember that when in the UK, everyone was doing MRIs for the prostate, and they had obviously, Mark Emberton had fantastic readers of these MRIs, right? And in a lot of other countries, they were doing one MRI a month and couldn't read it. And I think it's now maybe a bit the same problem with these PSMA PET CTs, especially if they're using these fluoride components. And I guess I would put like a really big attention mark there, and that people would need a learning curve to show first before they are allowed to read these PET scans.
Yeah.
Well, if I may, Declan and team and Silke, I agree completely, because what we have shown with the STAMPEDE data and the analyses of conventional imaging, which again we published in separate papers, the JAMA 2021 paper showed this, was that the bone scan and CT is a predictive factor. It's not prognostic. In other words, if you have the abnormality, you have the potential benefit of the treatment. And it is a concern in some of the PSMA papers that have been published, and important ones coming from Australia, that clinicians do change their treatment choices as a consequence of the PSMA scan. And the natural corollary of that, of course, is that a patient doesn't necessarily get treatment that they would benefit from, as defined by conventional imaging. So we need to work out what PSMA means and which particular patients need different treatments when they've got different PSMA scan characteristics, leaving aside the quality control issue, which Silke has quite rightly raised. And we have quite a problem in the UK, I think, in relation to the quality of MR reporting in prostate, which is very variable, I have to say.
Yeah, even in a country with a lot of MR. While we're on the PSMA thing, Renu, so, and also Noel, the other thing it dovetails into it is these high-risk men, because as Noel knows as a urologist, and us too, is when we think high-risk M0, we're thinking, NCCN, EAU, D'Amico classification, and we're thinking curative intent treatment, with a high rate of biochemical relapse, etc. But this is a bit of a different population to what we think, or some of our audience think is high risk. Wouldn't that be fair to say?
Yeah, I think it's important to really delineate this patient population so that we can somehow extrapolate it to our everyday care of patients. And apart from the criteria that Noel specified, there's also a smaller population of patients who've relapsed after treatment in the study as well, about 3%, I believe.
Yeah, tiny amount,
Yeah. And in that particular population, especially in Australia, they'd be getting a lot of PSMA PET scans.
So this is where I think PSMA PET is very confusing, though, because if we think of a new, as you would, Noel, coming into your practice, a newly diagnosed patient with high-risk query localized prostate cancer, maybe the PSA is around 20 or thereabouts, and if they have conventional imaging up front and look like M0, I presume you're still considering either surgery or radiotherapy, maybe with a multimodal approach with curative intent in mind? Or where do you switch over into, this is a STAMPEDE population, I'm thinking long-term ADT only, plus radiotherapy, and then I'm going to augment it with the ABI now. So how do you draw the line between, I might offer this man an operation as part of a high-risk localized prostate cancer with curative intent paradigm versus, no, I'm going straight for continuous ADT plus radiotherapy plus ABI? Where do you draw that line? Because I think this is the daily challenge from now on, because it's so clear that this is a standard care in the far out high risks, the PSAs 30, 40, etc. Maybe the people not fit for surgery. But what about the ones that are fit for surgery or definitive radiotherapy? Where are you going to draw that line?
Well, that's a really important question. And we got pretty good data on this. We've just submitted a paper where we've compared a UK practice with US practice based on SEER and the National Prostate Cancer Audit. And this is well over 100,000 patients in each part of the study. So if we take that M0 high-risk population, and we know as surgeons that radiotherapy high-risk localized disease is different in many regards to surgical high-risk localized disease. There are certain T3s that we wouldn't operate on. But leaving that aside, we think that about 20 to 25% of the incident population in the UK falls into this high-risk category. So it's a big chunk of patients. And in the UK, about 75% of those patients get treated actively. And the remaining 25% are the older, frailer patients, and I think we all know about those. But when we break that down still further, about 1 in 5 is treated with an operation, a radical prostatectomy. Now, when we looked at the US data, the breakdown is fairly similar in terms of incidence, but about 50% of those men using SEER data are actually being treated with surgery, not radiotherapy. And I suspect a great many of those are not receiving any combination treatment. For me, this is not right. This is not a standard of care. There's no evidence, as far as I can see, any level 1 evidence at all that surgery is the right thing for these patients as monotherapy. Now, when you look at the European guidelines for the latest edition, what they recommend is that surgery should be used as part of multimodality treatment. The evidence is labeled as strong, but for me, the evidence actually is really level 3 evidence. It's not at all strong because surgeons haven't done the trials. The clinical oncologists have done the trials. They've done them well. Surgeons have participated, but generally the surgical body internationally has failed, I think, to do what is a very straightforward thing to do. In other words, do the trial, and then you're on solid ground. You know what you're doing. And at the moment, I think surgeons don't really know what they're doing.
Says the surgeon. We have to remind everybody, eminent high-volume prostate cancer surgeon. Yeah, it's fair enough, Silke. Fair enough criticism. And look, in a moment we want to talk about the APCCC, and you can already see this week in responses people saying, "Oh, this is a great topic for APCCC to discuss." The Advanced Prostate Cancer Consensus Conference that you chair. But how do we deal with this real-world practice where surgeons haven't produced the data, but maybe a lot of us philosophically extrapolate out from radiotherapy data, or we believe just absence of evidence, etc., doesn't mean we're not benefiting these patients. I don't know. It's a really important point Noel makes.
I guess I want to say that probably in the European guidelines, Noel, what was meant was if you do surgery, do it at least in that kind of context of multimodality an approach. And that was the strong for that. So if you're doing it. But I have to totally agree with you. I don't know any data that has shown the added value of the surgery in that context. If you then know you have to give radiotherapy and hormonal treatment anyway. So I guess here the surgeons are probably, have to do the trials, the prospective trials, if they want really to go against a standard arm that is now extremely strong. I wouldn't know how many patients you would need to show an added value of surgery in that situation. Don't know, Noel, what do you think?
Well, I think you power the trial accordingly, and all of the trials that have shown useful information have been powered at about 1,000 patients, whether it's in Scandinavia, whether it's in the URTC, whether it's in the MRC, whether it's in the US. And so the surgeons need to get on and do that. But there is an important biological question, and that relates to the treatment of the primary. Because what we showed in the 2018 STAMPEDE paper, which was radiotherapy to the primary or not in relation to disease burden, is that the primary does drive the disease in the lower burden setting. And if you treat the primary, then the outcome is improved. You and I, Silke, have seen the extended follow-up data from radiotherapy for oligometastatic disease, and we know that the longer-term benefit is sustained in those patients. This will be published presently. But what's clear is that the primary has a big contribution to make to driving the disease early on. But then as the disease becomes more progressive, in other words, the burden goes up, then the metastatic component takes over and the primary doesn't drive it anymore. Then you have to have systemic treatment. So the combination of treatment of the primary and treatment of the low burden metastases is really beneficial. I guess what we haven't addressed is this question of whether surgery will have the same effect as radiotherapy. It's a big question, and we need to answer it.
Very.
We're not going to answer it today, I suppose. It's a great topic, and maybe we'll have you back on to discuss it again. It's one of the questions in APCCC all the time is how do we manage this primary issue, and do we extrapolate, and can we say this and that? And it's in the absence of data, the consensus statement is a useful way of looking at it. But before we wrap up on this really important paper, toxicity is something you mentioned earlier, Noel. So the plan was for 2 years of ABI for these patients, but there was quite a high discontinuation rate in the intervention arm, even just with ABI alone, I think, although nearly everyone did get to 2 years. So have you any final comments on the toxicity of the ABI and ABI-ENZA arms, just to summarise?
And also...
well, I think generally speaking... Sorry, Rena.
Oh, sorry. I was going to say, Noel, in your comment, maybe just any concerns that you also have about the long-term implications of 2 years of ABI?
Well, I think the first thing to say is that the combination of ABI and ADT was pretty well tolerated. Most of the patients got through that, and the side effect profile was not that dissimilar to ADT alone. Obviously, there was a little bit more toxicity, and we're all familiar with that with ABI. The addition of enzalutamide did add quite significantly to the toxicity, the fatigue and the hypertension particularly, with a smaller proportion of transaminase increases. So I think the combination, we're pretty clear that that's not helpful. We're currently working on the STAMPEDE data set. We've got a research project, one of a number of research projects in translation, looking at sarcopenia, osteoporosis, and other metabolic effects of these combinations. I think it's highly likely that there will be an augmented sarcopenic and osteoporotic effect with these agents. They are superandrogen blockers, as we know. And what we also know is that that has a major effect on musculoskeletal integrity. We'll have some answers to that, I hope, in the next year. We'll see. But I think one shouldn't forget the osteoporotic effect of long-term combinations. And I think that 2 years is quite a significant treatment in this population of patients who on average are aged about 68.
And I think now also, Arun, being able to say to patients that, these is the toxicity, we're planning this for 2 years, but have a look at the MFS and the OS when you counsel your patients. Do you feel that this is going to be very straightforward for clinicians and patients to accept?
Yeah, I think, look, I mean, I think in the end, what motivates patients in this situation, they want to be alive and well. And keeping them free of their cancer is the first step to being alive and well. I think we shouldn't forget about the toxicity. And I mean, people talk about the novel agents, the ABI and the ENZA, but ADT is not great for men in terms of their long-term metabolic, cardiovascular, bone health, etc. And I think we see fractures with ADT and with the addition of ABI ENZA, and so bone health and the use of early use of bone resorptive agents like denosumab, I think will become more we're becoming more and more aware of that. But in the end, yes, there's toxicity long-term, but I mean, men who aren't alive don't get toxicity, long-term toxicity. So the first step is actually keep men alive and well. And it's very clear that from this population that targeting the AR early, along with local control, is achieving that. Yeah,
and that's why I think it's going to very quickly come in as a standard of care around the world as well. And because ABI is quite readily available in many parts of the world, cheap and easy, it's probably from today will start to be used, by specialists advising their patients, even outside guidelines, I think.
And Declan, maybe I can add that. Okay, it's always nice to give bone-targeting agents, obviously, for osteoporosis prophylaxis. But then there is also lifestyle changes, right? And you Australians are very strong in that. So really telling people to do exercise, and your exercise programs from Australia that have been published are so strong that I would have no chance ever to do it. So I don't know about the men that you are having in your practice, but also like stopping smoking, not drinking too much alcohol. I just think this is something where the patients could do something, and we have also to remind them that these lifestyle changes probably really help something. in that situation, especially if we give now also the PRED with the AB in addition to the ADT in these patients who live a long time, hopefully afterwards.
And Silke, while you're there, do you want to tell us a little bit about APCCC? And we'll put the links in the show notes as well to this. But I mean, I think anyone listening to this podcast is aware of the original St. Gallen paper and then the updated Basel paper, incredible consensus meeting that you run, which is brilliant to attend in person, the most incredible plenary sessions. And then the panel vote is fantastic. But you have an upcoming virtual event, I think, ahead of next year's main 2-yearly meeting.
Yeah, because in reality, it would have been 2 years now, kind of. But obviously with the COVID, we have thought it may be safer to postpone it until April next year, the face-to-face meeting. That will probably then be a hybrid meeting. But a lot of people, especially Ian Davis in reality, have told us, no, but you have to do something because there's so much data coming and there's so much changes. Yeah. So we have decided to do a virtual meeting with only 4 or 5 people really coming to the studio live on the 9th of October for the hot topics. And one of the hot topics, you will love it, is PSMA, as you know. So in diagnostics and in therapy, because I think this PSMA PET makes a lot of more problems than it solves right now. So I guess, so that's really one of the important points. The second is metastatic hormone-sensitive disease, where we have just listened to piece 1 data and have now to decide who needs triple systemic therapy. And I think that's an important topic as well. And then all the other topics that Noel has already mentioned, the radiotherapy to the primary in the metastatic setting, that I think in Europe has been really taken on very well. But the Americans are still very skeptic, and we don't really know why, but it is like it is. And then the third topic is going to be molecular genetics, germline, and also somatic, the BARP inhibitors. And so this is the big, huge third session that we will have.
Yeah, so all just a one-day thing on a Saturday. Of course, it's middle of the night here in Australia, tediously as usual, but we're used to that.
Sorry. You have to be awake. So,
we will.
So Ian promised to be there.
Yeah, and Michael Hoffman's doing a talk for it as well, I think. So yeah, we'll put the link in, and it's a totally fantastic meeting, and the main meeting will be next March or April, I think, the in-person whole 3-4 day meeting. And, which is a fantastic meeting. And I remember coming back from the last one I run, having a chat with the team here, saying, look, this is a thing that we need to try and encourage our trainees and ourselves, our colleagues, to go to. It's the most incredible, intense meeting where it's only one room. It's not multiple parallels. You just sit in one place and you get these incredible updates from the world leaders in this area. And it's running with great humor as well by Silke and Aurelius Omlin, the goat bell and the cowbell, etc. No way are you going over your allotted time, but it is a great meeting. And
we hope so.
Now, Noel, the last question I want to ask you a little bit provocatively as a urologist. So it seems very clear to me that urologists and radiation oncologists should just be in charge of this whole disease space then, isn't it? Well, come on, Abby, it's easy. I know the dose of prednisone. What's the thing about LFTs and blood? I can't remember. I wrote it down somewhere. Anyway, this should be very straightforward for us in the clinic. We don't need to be troubling our very busy GU medical oncologists. We can just keep this territory to ourselves, I think. Is that right?
Well, I'm a firm believer in multidisciplinary care with patients. We have, on a weekly basis, I sit down in a joint clinic with my clinical oncology colleague. His research fellows there, our research people are there, our research nurses are there. It's a terrific clinic. And we each feed off each other. So I do believe that urologists should be prescribing the hormonal treatments. But I don't really subscribe to the notion that every urologist should be doing that. I think those who are skilled and trained and up to date, well, why not? But it's a collaborative approach, isn't it? This isn't a one size for the urologist and one size for the medical oncologist, clinical oncologist. You sit together, you discuss what's best for the patient, and you divide the patient up, send them down a certain line. And of course, one has to remember what the patient wants, because that's a really important question, which is not always resolved in a monodisciplinary clinic, which is always biased in my experience of it. And I'm as bad as anybody else. That we need to just put our egos to one side, I think, and get on with looking after the patients as best we can.
Yeah, look, I totally agree, of course. And it was interesting when these androgen synthesis pathway inhibitors came pre-chemo, you know, the companies marketing these drugs were running around trying to figure out, okay, well, who's going to be prescribing this? Who do we need to influence, you know? And they started coming to urologists thinking we have all the patients. And I think my main messages to them were, yes, your urologists have all these patients. And yes, it's right that you inform urologists about this new management option. And yes, if a urologist wants to initiate treatment, they should feel confident about using these drugs. But the most important message was really just getting the urologist and the radiation oncologist to know that there is a new management option for my patients. I need to discuss this with my multidisciplinary colleagues. And if he or she chooses to initiate themselves with multidisciplinary support, yep, sure. But you know, more likely, more typically, of course, for us is that we'll refer them to our GU medical oncologist. But people needn't get caught up in who do we need to influence to as a prescriber here. They just need to make sure the people who see these patients, and that includes this key paper, are well informed about this new standard of care. And if he or she wants to try and institute the standard of care themselves, sure, but it's just so important that they're aware of the standard of care so it can be offered to the patient most typically in a multidisciplinary fashion, I think.
Yeah, I mean, the 2 points, Declan, I think, and Noel makes a very good point, firstly, is that it really comes down to who feels comfortable looking after the patient. So I have no issue with urologists prescribing this as long as they feel comfortable managing the toxicities, but also then the long-term
progression.
The long-term sort of overall medical management of these patients, including their bone health and etc. So that's the first point. I think the second point is that in the end, it doesn't really matter as long as these patients get better, get optimal systemic therapy. And this is slightly digressing, but if you look at the MHSPC data out of the US, there's some very nice data from Niraj Agarwal and Dan George. There's the UK data. There's our own data that we published from the Victorian, from the from the PCOR, Victorian registry. In MHSPC, most men are still getting ADT alone, which is just so far below standard of care. I mean, we're talking about triplet therapy versus double in MHSPC, and yet most men are getting ADT alone, even in the US where they've got access to to the AR pathway inhibitors. So in the end, it doesn't matter who prescribes as long as men are getting optimal systemic therapy or optimal therapy, full stop, including systemic therapy. And yet men with prostate cancer aren't. And it's just staggering when you go down to the breast cancer clinics and you've got, these, poor women with ER positive breast cancer who are on 8th, 9th, 10th line chemotherapy. They don't leave anything on the shelf. They give everything they can. And yet we have men who don't get optimal, systemic therapy, who never get chemotherapy and that's the challenge for me. It's not who prescribes, it's actually getting these, translating these from these fantastic NEJM, papers, getting them into the clinic and actually implementing the data. That's the challenge, actually, more than who actually administers it.
Yeah, Silke, over to you. That's we need to keep banging that drum. Well, look, thank you very much, folks, for that fantastic talk. I really enjoyed that. It's such a privilege to speak to people who've been involved in what is an immediately practice-changing study. I think, Renu, you can clearly see that. It's not one of these, but what about this and what about that in the control arm? It's not. It's very straightforward, as Noel summarized so nicely earlier on. So we're very grateful to you for taking the time, and congratulations again to STAMPEDE, investigators, patients, hospitals, clinicians, everyone involved for this most amazing continuous stream of fantastic practice-changing papers that you continue to give us. So
it's a great pleasure, and thanks for inviting us on.
It was fun.
Thank you very much, Silke, and thank you very much, Noel, and thanks, Arun, for coming into the studio at 6 o'clock in the morning.
And I stayed awake the whole time as a medical oncologist at 6 a.m.
Is it because you got a brand new baby at home who's about 2 months old? That's all we have time for. We'll be back soon with some more ESMO-related stuff. There's still so much to talk about, and we will be back after APCCC to talk about some of the great stuff that they're discussing at that meeting in a couple of weeks' time. But that's it from us from now. Good day and goodbye.